You wake up with a stiff, aching knee. You reach for a familiar box in your medicine cabinet, pop out a painkiller, and within an hour the discomfort fades. It feels like a simple, harmless solution. But while that pill is quieting the pain in your joint, something else is happening inside your stomach. Something that unfolds silently, often without any warning at all. This is the story of how nonsteroidal anti-inflammatory drugs, the family of medications that includes ibuprofen, naproxen, and aspirin, can quietly damage the stomach lining, and why so many people don't find out until the damage has already become serious. To understand the problem, you need to understand how these medications work. Inside your body is an enzyme called cyclooxygenase, known as COX. It comes in two main forms, COX-1 and COX-2. When you have an injury or inflammation, COX-2 activates and produces signaling molecules that trigger pain, swelling, and fever. Anti-inflammatory drugs work by blocking COX-2, which is why they reduce pain and inflammation so effectively. But COX-1 is different. COX-1 is always active. One of its most important jobs is continuously producing prostaglandins, a group of protective compounds that are essential for the stomach's survival. These prostaglandins stimulate the stomach to secrete a thick mucus layer that coats and shields the inner lining from stomach acid. They also promote bicarbonate secretion to neutralize acid, and they maintain blood flow to the stomach wall, so that damaged cells can repair themselves. Think of prostaglandins as the stomach's permanent defensive shield. Here is the problem. Most common anti-inflammatory drugs block not just COX-2 but also COX-1. The moment COX-1 is suppressed, prostaglandin production drops. The mucus layer thins, bicarbonate secretion decreases, blood flow to the stomach wall diminishes. Yet stomach acid keeps pouring in at the same rate. With the defenses compromised, that acid now makes direct contact with the unprotected stomach lining. This is the core mechanism behind anti-inflammatory drug ulcers, the collapse of the stomach's protective system through prostaglandin depletion. There is also a second layer of damage. Anti-inflammatory drugs are chemically acidic, and when they come into contact with stomach lining cells directly, they disrupt the phospholipid structure of cell membranes and interfere with the mitochondria inside those cells, disrupting their energy production. This local damage happens the moment the drug touches the lining, independent of the systemic effect. Two simultaneous attack pathways means the threat to the stomach is compounded. Perhaps the most dangerous aspect of this process is how silent it tends to be. Because anti-inflammatory drugs suppress pain signals throughout the body, many people feel no stomach discomfort even as significant damage accumulates. Studies show that a large proportion of patients with anti-inflammatory drug-induced ulcers experience no notable symptoms until a serious complication, such as bleeding or perforation, occurs. The absence of pain does not mean the absence of harm. The clinical numbers make this impossible to dismiss. Research consistently shows that between 10 and 30% of regular anti-inflammatory drug users develop gastric ulcers. The risk of complications like bleeding and perforation in anti-inflammatory drug users is roughly 5 times higher than in non-users. Among elderly anti-inflammatory drug users, the hospitalization rate for peptic ulcer disease is nearly 4 times higher than among elderly non-users. Age raises the stakes considerably. Large-scale prospective data show that adults aged 65 or older who take anti-inflammatory drugs face a 2.25 times higher risk of upper gastrointestinal clinical events overall, and an alarming 4.09 times higher risk of severe complications including perforation, obstruction, and serious bleeding compared to younger users. Older adults have reduced mucosal repair capacity and are far more likely to be taking additional medications, like anticoagulants or antiplatelet drugs, which synergize with anti-inflammatory drugs to further elevate bleeding risk. There is another hidden multiplier. Helicobacter pylori is a bacterium present in the stomach lining of a significant portion of the global population. It independently damages the stomach's mucosal defenses. When someone with an H. pylori infection also takes anti-inflammatory drugs regularly, the combined risk is not simply additive. A meta-analysis of relevant studies found that people carrying both risk factors face a 3.53 times higher risk of peptic ulcers and bleeding complications compared to those with either factor alone. Not all anti-inflammatory drugs carry equal risk. A 2025 review published in a Korean gastroenterology journal classified these medications into 3 risk tiers. Ibuprofen, which is the most widely used over-the-counter anti-inflammatory drug, carries a relative risk of approximately 1.84, placing it in the lower risk group. Naproxen and diclofenac fall in the intermediate range. Ketorolac and piroxicam, by contrast, carry relative risks of 11.5 and 7.43 respectively, placing them in the high-risk category. The choice of which specific drug to take can mean the difference between a modest and a dramatically elevated danger. The first 30 days of use carry the highest concentration of risk. Many people assume that only long-term chronic use creates danger, but short-term high-dose use also carries real consequences. Higher doses increase the risk of gastrointestinal complications by 2 to 3 times compared to lower doses, and combining multiple anti-inflammatory medications or taking them alongside alcohol amplifies the danger further. There are practical steps that meaningfully reduce risk. Taking these medications with food blunts, direct contact with the stomach lining, using the lowest effective dose for the shortest necessary time, is the foundational principle. For people who need long-term use, those over 65, those with a prior ulcer history, or those taking anticoagulants simultaneously, clinical guidelines recommend combining anti-inflammatory drugs with a proton pump inhibitor, a type of acid-suppressing medication. Clinical trial data show that this combination reduces the rate of ulcer development from 17% to below 5% in high-risk patients over 6 months. For pain relief without the need for anti-inflammatory action, acetaminophen carries substantially lower gastrointestinal risk and is worth considering. If any of these warning signals appear during anti-inflammatory drug use, they deserve immediate attention. Upper abdominal burning or pain, persistent nausea, dark or tarry stools, blood and vomit, or unexplained fatigue. Dark stools in particular can be a sign that bleeding has already begun. In the stomach or intestine, the pill that quiets your knee is doing its job, but it may be doing something else at the same time, something you cannot feel and cannot see until it becomes too serious to ignore. Knowing how these medications work and what they ask of your stomach in return is the kind of knowledge that protects you.